Good evening, everybody. I appreciate y'all accommodating my schedule change, knocking it back a little hour. So we'll go ahead and get started tonight. We're going to dive off into the medical side of things. We're going to, let me change a setting real quick. All right, sorry. So we're going to dive off into the medical side, go over the medical overview. It's not a whole lot of slides. It's, I could probably make it last a while, but I think it's like 53, 54 slides. So that's in my way. We talk about medicine. Medicine applies the fundamental knowledge to provide basic emergency care and transport based on assessment findings of an actually acutely ill patient. So it's based off of our assessment. If we're going to declare this a medical and or trauma patient, and we move forth on how our treatments are from there. They're basically going to be the same, but we'll do a little bit more, a lot more in detail and more of the assessments on trauma patients. So the medical overview, medical assessment and management of a medical complaint, pathophysiology, assessment, management of medical complaints, to include transport mode and destination decisions. We'll go over infectious disease. We want you to be aware of a patient who may have an infectious disease, assessment and management of, and a patient who may have an infectious disease, which you're going to treat them the same exact way. We're just going to wear particular, like we may wear gowns instead of just regular PPE. Just because they have an infectious disease doesn't mean that we can't treat them. We just have to be more cautious on our interactions. Patients who need EMS assistance are generally having a medical emergency. It could be trauma or medical or both. Trauma emergencies involve injuries resulting from a physical force applied to the body. Medical emergencies involve illnesses or conditions caused by diseases. It's like, let's say, like flu and croup, viruses, all those things fall underneath the medical side. So some types of medical emergencies, you have a respiratory emergencies, which occur when the patients are having trouble breathing. We know those, we kind of follow that. We got a cardiovascular side is more of the heart, it's the ticker. We have those issues affecting our circulatory system. We have our neurologic, obviously was with the brain, and gastrointestinal, include have appendicitis, diverticulitis, pancreatitis, and list goes on and on and on from that. So we break those down into the different categories. You may see a regular physician when you come in, but you may see a GI specialist because it's resorted to be an abdominal pain. May have to do like IV contrast, particular scans that will show.
Crohn's is one of those that's not seen, but is real bad when the gastroenterologist.
My mom had Crohn's very, very bad. My sister has a doubt of it.
My oldest,
but Crohn's is very serious.
Yeah, my oldest, she has Crohn's. She's 15 and she's out of remission actually. And she takes Humira, but we're having issues with strictures and fistulas. They had to operate year before last, and hopefully they won't have to operate again and take any more of the small or large intestine. Because
that's a fight. Crohn's disease is a constant fight. That's like a sickle cell crisis. That's a constant fight. Whew. Bless them all. So urologic, anything that has to do with kidney stones, UTIs, anything like that. The most common endocrine emergencies are complaints of diabetes. Hematologic emergencies may result from a sickle cell. We talked about that, and blood clotting disorders. Immunologic refers to the body's response to foreign substances. Let's see, toxicologic emergencies report about poisoning, substance abuse. Some medical emergencies are caused by pathophysiology and behavioral problems, which is also referred to as behavioral. You may refer to a psychiatrist or a psychiatrist. You may go to the psych ward. Gyno issues or falls into the female reproductive organs. I'll tell you, I despise teaching the female reproductive system. It's nothing personal. I just absolutely hate it because it's like I'm teaching something that I haven't ever like faced in my entire, like personally, I will try to find a female that I know that will do a really good class on that one night and allow her to teach. It's just one of those, I'm like, I don't know. I mean, I can tell you how to treat things, but I don't know. Yeah, I just don't like teaching it. It's my point. Here's some different types of the table, types of emergencies, what we just went over. It's in your book on 15-1. It's just the table of contents, just kind of shows you how the rest or the emergencies are broken down. Oh, let's see. So assessment of a medical patient is very similar to a trauma patient, but we have to figure out the nature of illness. Once we figure out the nature of illness, we can talk about their symptoms and chief complaint, but if we're not sure if they're beating around the bush or they're trying to get this, well, this is hurting. Well, I don't know about any. You got to figure out why. So my thing is when everybody's like that, I'm like, hey, so why did you call me here right now? That's different than 4 hours ago. That's what I need to worry about. And then if their big complaint is, well, like my toes are swollen. All right, we're going with toes swollen. You want to go to the hospital for that? Oh, by ambulance. Okay, let's destroy the 18 cars that are out front. That's kind of what's wrong with our hospital system too, as everybody uses the emergency room as their regular physician. So figuring out that nature of illness allows us to move forth, and we start talking about symptoms, and then we can potentially relate that to a particular area like the abdominal pain, respiratory, cardiovascular. So that's where we want to kind of base it and start getting our answers once we move forward. So establish an accurate medical history. Use dispatch information to guide your initial response, but don't get locked in on that. That may not be the best answer that was given by the patient to the dispatcher and relate to the ambulance. And it's not the middle person's fault. It's just loss of translation. Injuries may distract you from the underlying condition. So look deeper. Don't let the evisceration or where their guts are coming out of their stomach. Don't let that stop you. That is like, oh my God, what's that? But that's not an end all tell all. Let's leave it there. Tunnel vision occurs when you become focused on an aspect of the patient's condition and exclude all the others. It's the same thing if you saw that evisceration, which may cause, if you do the tunnel vision, it may cause you to miss very important injuries or illnesses. So again, early in your career, I see a lot of technicians, EMTs, paramedics get very tunnel vision, like they put their blinders on, like we put horses on when we ride horses, because we don't want them to see what's going on. So that is very cautious. We need to be careful about that because we will miss things. And as a provider, we have to make sure that we don't get blinded and see the big picture so we can treat the entire picture. We can lose patients just because we're not paying attention to the entire picture and we're focused on that one little thing that doesn't really, the squirting blood that's coming out their back or the inside of their leg or femoral that's soaking up in their pants, that if we would just continued our assessment, we would have found it. So those are things we have to be cautious of. So some of your assessments may be difficult for an unresponsive or hostile patient because we know the scene is not safe. Now something has occurred that is stopping us from moving forward with this patient. Always try to be very professional, maintain your bedside manners, try to be calm, non-judgmental. It may be easy for some of us, it may not be easy at all. Refrain from labeling a patient. Don't let your opinions, or how do you want to put this? Don't judge too quick on a patient. And a frequent caller may have some different complaints at some time. And the frequent flyers know the system. They know how things work. But at the same time as that day that you ignore them, it's going to be a true emergency and then they passed. And that's on you and not because, yeah, that's it. My wife's telling me, she heard me. Don't profile your patient because of location, time, events. There may be something else neurologically going on, behavioral going on that has caused the situation. So profiling of a patient is very, very wrong, and it can lead you down a dark path of trying to assess this patient and trying to provide proper treatment. So go in each patient with an open mind, but again, you have to be cautious on what all you believe for each patient. So when we talk about our scene size up, the biggest thing is we need to make sure the scene is safe for me. I am the most important person on the call, in my opinion. Then I'm going to worry about my crew, and then I'm going to worry about my patient. We're going to use standard precautions to determine the number of patients you have, whether or not you need additional help, which is, again, refer back to your National Registry checkoff sheet. Those are some of the top first important questions that you mustn't ask. So we determine our nature of illness, the index of suspicion you're aware of, and concern potentially serious underlying and unseen injury or illness. So be cautious. Initiate spinal immobilization if you think it, even if you have a presumption, you're like, I don't know if this dude fell. I don't know if he got hit. I don't know what happened. It's easier to apply it and allow the hospital to take it off versus you going back hours after dropping that patient off and be like, dude, you know that guy's paralyzed now? He had a C1-2 fracture. Now he's paralyzed, and you're just like, I could have stopped that. You could or could not have, but if you suspect it, always put it on, man. Those things are cheap. Let the hospital just do a CT real quick and then rule that out. Primary assessments, do a general impression of the patient. Perform a rapid exam of the patient, quickly determine the patient's level of consciousness. So what we need to do is figure out what's going on and make sure that we don't have any life threats. Figure out our life threats and fix them. Quickly determine the patient's consciousness by using AVPU, if y'all remember the alert, verbal, painful, and unresponsive acronym that we use to help us gain more gainable knowledge and better treatments. So we use these and moving forward. So now we're trying to get our initial assessment. We're gaining our general impression. Just because Fred looks like a bag of ass, maybe he always looks like that. We haven't seen Fred. We don't know who Fred is, but let's just take it for face value and move forward. And then once you realize it's like, wow, Fred always looks like that, and he's just having some diabetic issues. Fred's had a hard life. Airway and breathing. Now we're on our ABCs. In conscious patients, ensure that the airway is open. If they're talking to you, they're okay. They're breathing. I always like to say when people are like, I can't breathe, I need some oxygen. Well, stop talking. It's okay. Do this or this, and we will be on the same page, I promise. So I want you to check the respiratory rate, depth, and quality. How is it? Is their rate good? Is it sustainable to life? Are they shallow breathing? Or are they breathing normal depth? And the quality, is it of good quality? Does it have any like that's not good for them. Consider applying oxygen if the breathing has been affected. Again, I've told y'all multiple times, don't not give them oxygen. Provide the oxygen that's going to be the most helpful for them, and allow them to just, okay, you need it, we'll take it off when we get to the hospital. For unconscious patients, make sure you open the airway using the proper techniques. Again, if we suspect at all that there is a spinal injury, we're going to use a jaw thrust. If we don't suspect it, a head tilt chin lift, and we provide 2 rescue breaths. If those rescue breaths work and the patient starts breathing on their own but is still unresponsive, that's moving in the right direction. We're doing a very good thing. Anytime a patient that is in shock, they complain of difficulty breathing, or your finger probe, this shows that they're having low O2 sats. SpO2 is less than 94, we give oxygen. So remember that anytime that SpO2 is less than 94, provide oxygen. Unconscious patients may need airway adjuncts. Remember, we talked about that. We have the nasal, and then we have the oral. So those are the 2 that you can drop in by basics, and that can help open the airway and provide a clear passage that we have put into this patient for them to breathe. Now we're on circulation. In conscious patients, by check In a conscious patient, check the radial pulse and observe the patient's skin color, temp, and condition. For unconscious patients, assess the circulatory at the carotid. So I'm going to check here. If everything's good here, if everything's good there, you know that the heart is at least pumping this far. So that's when we're here. In conscious patients, we can reach down to the radial, we can go to the brachial. If we have a good pulse there, continue your assessment. It's pretty good sometimes just to walk up, and when you go to shake their hand and reach around and feel their pulse at the same time. Be like, hey, it's fine. I'm just checking your pulse while we sit here and talk, and hold their hand. You're checking their grip strength at the same time. I'm not sitting here just trying to bear in, but that's fine motor skills just to sit there and hold your hand. If their fingers are moving a little bit, that's perfect. That's our normal response. But let the patient know what you're doing too. Our transport decisions. The following patients should be considered in serious condition and in need of rapid condition. A patient who are unconscious or have an altered mental status. Patients with airway or breathing problems, and patients with obvious circulation problems, such as severe bleeding or signs of shock. If the patient does not meet the criteria for rapid transport, continue your assessment on the scene and be prepared to transport when you have completed assessment and treatments. So if I can stay in play or I can load and go. Remember, those are the two categories that I'm going to put a patient in when I'm ready to, once I make that decision, be like, all right, well, they're having altered mental status, and oh man, they're just not, like, they're not answering my questions. That's a load and go. We don't have time to stay and play and chit chat to the family. It's time to get gone. We want them at the facility the fastest that we can get them there. When I want to know about their history, I want to know what's causing this problem. What caused me here? I know that you've had diverticulitis for 50 years, but why did you call me tonight about your diverticulitis? What has made it different for you to call 911 since the last 50 years? So we want to investigate the nature of illness by inquiring about their chief complaint. Just ask them, okay, so you're here because of your toes are swollen, but you got diverticulitis it's a flare up. So tell me which one is the most important that we help you with right now. And they're probably going to be, oh, my toes are swollen. All right, roll with it. For an unconscious patient, survey the scene, make sure for medication containers, or look for pill bottles or any type of other medical devices. Sometimes just looking around the scene may give you more answers than the patient will or family. And they'll be like, I haven't seen Fred in 10 years. Just found out he was my uncle. I don't know what's wrong with him. So looking around the scene, trying to assess what's there, and just grab some information there. Look at some mail. Oh, well, this is Mr. Fred Williams. Hey, Mr. Fred, how you doing? That is something that may help. Again, I'm notorious for opening up the refrigerator, looking in the butter box to see if there's any diabetes medicine there. That's where everybody keeps it. It's there. It's friendly. It's heck. I mean, heck, some of my medicine that's cold stays in the same place. So I want you to obtain a sample history to ask questions about the patient's chief complaint. I want you to do the OPR-QST mnemonic also. Those allow you to gain information about the patient. I'm asking those questions and trying my best to either remember it or write it down. I highly recommend for your first time, get you some 2-inch tape and write it on your arm. I mean, tape it on your leg, write it on your glove. I like to write on the top part of my hand because I touch everything and I'm like, oh, that's bloody. I can't see that. So then when I'm writing my report, I can take my glove off and lay it out if it's not bloody or nasty, anything like that. And I have all the information I need. So you're asking these questions, and if you have a great memory, man, do you? That is amazing. But if you need some help, write it down. I'm sorry, I'm having to steal some chocolate. No, my wife got me some nice chocolate for Valentine's. That was sweet of her, so it kind of got my attention. So ask these questions, because all it's going to help you do is do a better report for the patient, a better handoff note, And you got to tell the hospital something besides, no, I don't know. They just called us and told us to come pick him up, take him to the hospital. What's his name? You were at his house. Yeah. So again, be cautious how you go across that fine line of being nosy or plundering through their stuff versus gaining information. So secondary assessments, some of them may happen on scene or during your transport. In some cases, you may not have time to conduct a secondary assessment because you're still treating their initial complaint. The trauma is taking up all of your time, and you're just not able to do that secondary assessment. Some physical examinations, all conscious patients should undergo a limited or detailed physical exam based on their chief complaint. For unconscious patients, you should always perform a secondary assessment of the entire body, head to toe, to obtain clues to assess from the problem. Full body assessment should help you attain clues and should be performed quickly so it does not delay transport. Now the chocolate's stuck to my teeth. So we should not spend any longer than 10 minutes on scene, no matter if it's a trauma or regular medical patient. I mean, if there's a extrication or a delayed circumstance to where you got to have help move the patient, maybe they're obese or an extrication, like I said that, but 10 minutes is long enough. That's a lot of time. Try your best to get to the hospital the fastest that you can and move forward. I mean, this patient needs some extra help, so we want to try to get them there as fast as we can. If the patient's condition warrants a secondary assessment, what I want you to do is examine head, scalp, face, the neck, chest, abdomen, legs, arms, and the patient's back. Now, when we do the back, what you need to do is if you're putting them on a spinal board, you want to assess that first. Once you log roll them, you want to assess that detailed. And then once you put them on a backboard and secure them, you're really not going to be able to move them again and check that backboard, check the back for any changes. So that's a one and done show. But when you get down to the head, scalp, face, neck, chest, abdomen, arms, and legs, that you're going to do a decap BTLS for each individual area. Can you feel me here? Sir, do me a favor, smile at me. Squeeze your teeth down. Does it feel like all your teeth are there? If they ain't got no teeth, you can't ask that question. Men specifically ask the question, ma'am, do you feel like there's any trauma if they're complaining of abdominal pain to your pelvic region? You can grab the pelvic area and feel the hip bones and check to see for stability, but we're not going to go any further. Women and men at the same time. I do this. Sir, does it feel like all your male parts are there? Does it feel like everything's intact? In man's mind, that means, oh, I got to check. Yep, it's there. You can ask a woman that and they're like, yeah, they're there. And they're sitting here talking to you like this. But a man, they're like, yep, they're good. So expect that. So that's just the way that you can have them on. You're checking their mental status. You're getting them to do something for you when you assess that area. Vital signs. These are super duper important because we got to have a baseline. We got to have an assessment and then our continued vitals. How often do we do vitals on the regular medical patient? Somebody tell me. I'm going to eat my chocolate.
I know when we transport dialysis patients, we usually only do it twice. Once when they get in the van and probably once on down the line, and that's it. We load them and get them up out of there.
About what, 10 minutes?
Yes.
So I was trying to make that last longer, sorry. So for a true medical patient, you're going to assess the vitals every 10 minutes. Some places will tell you 15. Do it 15. It's whatever the company's policies are. On a traumatic patient, you're going to do it every 5 minutes. I guarantee that's going to be a test question at some point. It could be national register question. All right, so when we get our blood, we're going to do our vital signs. This is going to include blood pressure, respiratory rate, pulse, SpO2, and it can go all the way down to a CBG level, which is the blood glucose. It just depends on what your agency requires and what they will allow you to do at your basic level. Those are a baseline vital signs because when you have a basis, and that's your baseline vitals. Every time you check them 10, 15 minutes, are they improving or are they getting worse? You got to know either way. So 90% of the time, you always do your very first one. And if you do like readouts and all that on your monitors, they'll have them in chronological order. I do my first one. And if I'm documenting a long chart, if I have 15 of them, I find, 7, and mark 7, and then I do the last one. I think my local limits that I wrote for, I think they require a minimum of 2. You can add more than that, but most time people are like, oh, it's 2, it's all you get. You don't ask me to do any more than that. So our reassessment. So once the reassessment and treatment have been completed, you're going to continuously to reassess the patients, and it's going to begin throughout the entire transport. So you got to them on scene, you assess them, you start doing some treatments. You may not have, you may wait till you got to the ambulance, but you're going to repeat the primary assessment and to reassess their chief complaint. Now, Mr. Fred, I want to make sure, you told me earlier that you were having trouble breathing. Is the oxygen helping you or not? I've had trouble breathing for 20 years. You're going to hear that are either, yes, that's helped me, thank you so much, or they're just not going to answer you. But we want to make sure that they understand that we're trying to help them and we're acknowledging them about their chief complaint. It says review all treatments that you have, reassessment of your interventions, documenting and develop changes. And when we say develop changes, you may have to add more vital signs in there. If it's improving or if it's going south, you're going to need to document the changes. The changes is very important. No, don't want to talk about that. All right, management, transmit, destination. So most medical emergencies require a level of treatment beyond that available in the pre-hospital settings. May require advanced testing available in the hospital because there's some stuff that we can't do as an EMS. I don't carry a portable X-ray. I don't carry MRI. I don't carry that cool stuff. But I can give them enough treatment to get them there. Maybe beyond your scope of EMT to administer any type of medications, but by administering a medication by an EMT requires direct permission from medical control. It can be online or by phone. EMTs can use the AEDs. We know that. So you're only going to use that on a patient who is pulseless or they're apneic. Every agency should have at least a AED that if you're on there like a football standby, or you're going to have a 12 lead, or now they're having our 15 leads. Those should be at a minimum state requirement no matter what. I've seen some of the larger agencies here, they send out a basic truck. It's got a basic bag and an AED, just because that's what they can get by with. And I don't mean that as like, oh, they're skipping. No, that's just what is required to run a basic truck. So we talked about scene times, but you want to, again, here they're saying gather as much information as you can. Critical patients always need transport, and those patients include, again, the altered mental status, airway or difficulty breathing, signs of circulatory compromise, and the very old or very, very young. I like to say anything less than their teens needs to be a rapid transport. And it's not like, oh, I'm gonna go light the sirens, but once they compensate and they go downhill, it's fast. It's like, oh God, this baby's not breathing now. And literally you're just like, hey, I'm Wally. Oh, so those babies compensate for so long. And then when they do, done. Same thing with our geriatrics. They just try to pass it off as, oh, this tightness in the chest has been here for 5 days. It's nothing big. They're done. It's because a lot of your elderly patients don't like to ask for help. So when they ask for help, they feel like they're hindering people that because they need them to help them. So that's a thing that you also have to realize and kind of try to fight past that. Type of transport, life-threatening conditions or lights and sirens. The patient is not in critical condition, we can go no lights and sirens. Modes of transportation, obviously, there's two ways. You can go by ground or you can go by air. There's really no other way to describe those two modes. Obviously, here is a box style unit. I forgot what type style, because they have different types, like the vans, the modular. This is a modular style. As you can see, the box is set on different than the truck and the chassis. I can't remember that. So that is a ground unit, one of the ever ground units. There's a, I think that is, I think that's a Bell 407, if I'm not mistaken. But you can see that's a light flight. That's a load through the back. Some agencies are smaller. This is a dual engine, so that's actually nice. They load them through the back. It's always two providers. You may have nurse practitioner, paramedic. They 90% of the time don't do paramedic, just because they need the dual scopes on an ambulance. I mean, on an air transport. So at Destilation selections, we don't want to take the traumatic call to the local Band-Aid station. If it doesn't meet their ability to help them, let me back that up. If your protocols and your company policy says a type of emergency of this, and this type, take them to your most your closest facility. Sometimes I haven't done that. Just because it's not going to be beneficial. Sometimes I've done that for, I worked a very, very young pediatric cardiac arrest in a local daycare here. And we transported them to the local facility. And I call it a Band-Aid station. I've been there, I've been taken care of there. The people are good, but they're not a pediatric hospital. So with that being said, is that got taken to the most appropriate facility at the time. So they were the most appropriate because they had physicians and they had respiratory techs. I didn't have an airway, so I had to get something. And they were less than 2 minutes away. So sometimes there's a fib in there. Paramedic sides can make those decisions, and we can fight the ability to go a little bit further. Infectious diseases. So again, it's person like any other patient. They don't have the cooties just because they got the bug, but you just need to know what type of personal protectives that you need. You need to make sure that you have your gloves, your mask, your gown. You can have certain eye protection. I don't like the words double glove because you can have an instance where your outside gloves break, or your inside gloves are too tight and they break. So I don't ever double glove. And unless I'm working like personal stuff here at my house, I don't like the double glove on a scene because of that particular reason. Gather patients' history using OPQR, see all that cool stuff. A lot of times if you're doing an interfacility transfer and you know that they have a particular infection or disease, since we're talking about that maybe you may have to use other type of precautions for personal protective equipment. Obtain a sample, we talked about that. This is really the same assessment we're going to do on any patient. They're not any different. And they're talking, so we're not talking about COVID, or we're not talking about the flu here, like meningitis, or what was that one before that I forgot the one right big before COVID. What was all that one?
Ebola.
That's it. I've taken care of Ebola patients. They the same. I actually got to go to Indiana and go to a level 1 Ebola center. And they taught me some amazing stuff, and I got to deal with these patients that were free flowers, which they were flowing out of every cavity of their body, and some that were like I'm just in pain, like everything hurts. And they all had Ebola, but we treated them the same. They put their pants on the same way I do. We know different. We just here to help you and take care of you. And that's just the way that I try to go to every patient that I go to is we know different. We the same. We just in different points of our lives right now where I'm taking care of you and you still taking care of me. So our general management procedures, let's see, focus on the life-threatening conditions, identify primary assessment. Again, we know that. Be very, make sure your bedside manners are up to point. They just don't feel good. These people are sick. Place the patient in a position of comfort. It doesn't matter what position that is. If they are comfortable, I've taken people to the hospital that have sat on their knees and their head laying down on the stretcher. That it was the most comfortable for them. I mean, it's position of comfort. Okay, transport. It was heck writing that report and getting med control to understand why I allowed the patient to do that. But once they treated the patient, they were able to see why we had to transport them like that. It says always follow your agency's exposure control plan in case you've been exposed to anything, and dispose of any supplies that you use and washing the linens. Certain hospitals have certain bio containers that you can drop that stuff in, red bags for any trash that we use. We can dispose that in the hospital facility too. So make sure the standard procedures or standard precautions on decontaminating your unit, cleaning your unit, how you have to fill out the proper paperwork, because even if you've been exposed, let's say we have a needle stick today, what is today? The 15th of February, 2022. We don't have no problems. We're like, oh, it was nothing. It's okay. Well, in 4 years, you develop some god awful illness. It could have been related to that, but if there's no paperwork that documents that, we can't go back on the workman's comp about that. So always fill out the paperwork. I'm very familiar. I'm an over notification because I have a wife and kids at home. I want to make that sure that I don't bring anything home and that their safety is the most. So I try to make sure to document anything. So the epidemic and pandemic. So the difference is epidemic, new cases of disease in a human population substantially exceed what is expected. And a pandemic is a disease outbreak that occurs on a global scale. We're all pretty familiar with that. I hope that we can see the light at the end of the tunnel with this, that things are starting to subside about the COVID precautions, and this pandemic is starting to become the normal. And I think that's going to be the new norm, is what we deal with in things. So let's talk about this. This is pretty easy for here. So influenza. Those with chronic medical conditions and compromised immune systems, most of the time you're going to see that in the very young and the very old, because they haven't been exposed to as much, or their immune system is just wore out, it's tired, just like their body. And this is all going to be transmitted by nasal secretions, aerolized droplets. It's the same thing that we deal with the COVID. It's still a influenza. And that's what I've said from the get-go is, yes, COVID is bad. We have lost some good people to that across the world. We still continue to lose people through that. But it's nothing different than what we deal with on a normal basis when we're talking about influenzas. We just have to be more cautious because of the infection rate. That's a personal thing. I still have to wear my mask when I go offshore on the oil rig, but I don't frown on it because I respect everybody else's opinion. If you want to wear a mask, wear a mask. I'm proud for you. I will support you all day long. But again, a lot of people forget about this and like, you just exposed yourself, but you're wearing your mask. So tell me where we're at on that. Let's see. For diseases, you can always be passed through the respiratory route. We know that. Wear the proper PPE when we talk about eyes, gloves, and HEPA respirator or an N95. Surgical masks are not made to keep surgical masks are made from what I have to you, not from you to me. So if I'm wearing a surgical mask, I'm trying to keep the exposure one way. But an N95 is a particulate mask. We need to be understanding what particular mask that I must wear. Do I need to wear an N95 mask, or do I need to wear an N95 respirator that has the cartridges on it? I just need, I don't know which one I need to wear because I'm not sure what the influenza, the flu, I'm not sure what they have. That's why we have specialists that can tell us that. We have our HEPA respirators or N95s during aerosol generations. When we talk about if it's aerolized, we can put on our respirators. Most companies have your annual influenza immunizations. They will do fit test on you to make sure that you have been fit tested for an N95. That's where the facial hairs have to come in place. But that's a standard procedure. A lot of companies offer flu shots. A lot of companies will pay for those. They will be able to push that and go forth in that part. The herpes simplex, that is a very common virus. It is carried by humans on a daily basis. Systematic infections cause eruptions of tiny fluid blisters called vessels that appear on the lips or genitalias. They can cause more serious illness like pneumonia, meningitis, and a lot of the young kids. The very old can also get the meningitis. And in immunocompromised patients also will play a big factor on that, on getting sick. The primary mode of infection is through close personal contact, so standard precautions are generally sufficient to prevent the spread. We talk about sores like lip sores, cold sores. Those are just like the herpes, and they pass the same way. Some can be caused by stress, some can be caused by an infection. But just because you see them have the cold sore on their face, you're not like, he's got herpes. That's not really the case. It could be, but again, we don't need to form that general impression. We just need to be like, how you want me to fix that? How you what you want me to do? I mean, we can tell you to go to CVS and what to get.
I was told it's a herpes simplex A, which is a different form of the herpes. But I used to have them a lot, like when I was a kid, and the doctor told me I was missing an enzyme, and they gave me a vitamin, and I didn't get them no more. So
that is awesome. That was that from the cold sores?
Yes.
That is, I've heard that, but you're actually
It's
the first person
the vitamin's
that I
called
know.
L-lysine.
Okay. They just gave you a shot, or you just had to take that on a regular?
No, I took it for like a year. When I think I was like 10 years old.
Okay.
I took it when I was like a year old, or
So
for a year when I was 10, and like I've not had them since.
So is it lysine?
L-lysine. Okay, it's a vitamin.
I know exactly what that is. I carry that. Matter of fact, one of my job I was at today, we carry that. So I'm very familiar in that. Cool deal. Thank you for the information. HIV infections, ENTs face, we see this, I'm not gonna say you see it on a daily basis, but most of the patients I've ever come across that have AIDS or HIV, they'll tell you. They're just not gonna tell you in an open setting. A lot of them will tell you, hey, just to let you know before you start this IV, I have AIDS. It's okay, baby. I appreciate you telling me, and thank you so much. But I'm still gonna start this IV on you because you need it. But we're gonna be careful. I'm gonna let the hospital know too, if that's okay. Or would you like to tell them? No, that you can tell them. I just don't want everybody to know, and I don't want everybody to know. AIDS can be fatal. We do have treatments for that. It can be treated. They do have flare-ups. We know that it is transmissible through blood. You're not going to transmit that in a work setting. So if somebody working alongside you in an office job is HIV positive or AIDS positive, you're not slopping spit. You're not trading drinks, you're not, sexual interactions. So that risk is very low. It can mysteriously happen, but your risk of infection is limited to exposure to infected patients or body fluids. But again, I still reported that I had a contact with an HIV patient, started an IV, no fluid contact came in amongst me, but I let my company know. I let them know that I had that. TB patients, I've got records of it because of all my encounters. Many patients with HIV show no symptoms. They always appear to where just some of them are healthy, some of them are not healthy. Make sure, again, always wear your proper PPE. You have gloves on, eyes, face protection. Depends on whatever your company requires. Anytime that we go to dispose of any items, equipment, trash that has had come in contact with an HIV patient, bodily fluids, blood, anything like that, we need to make sure that it's disposed properly and into a bio container. Obviously, if they have any open wounds, we want to make sure those are covered and secured. If you think that the patient's blood or secretions may have entered your system, seek medical advice and notify your infectious disease officer. I'm not really sure who an infectious disease officer is, but most of the time it is HR, and everybody's like, "Oh God, I got to talk to HR." No, I just need them to know about I'm sick. Like I might be sick. I don't know. Hepatitis. So it's an inflammation, often infection of the liver. It can cause a number of different viruses and toxins. Let's see, there is no way to tell which hepatitis patients are which hepatitis patients are contagious. Hepatitis A can be transmitted only from a patient who has an acute infection, whether hepatitis B and C can be transmitted through long-term carriers who have no signs of illness. A carrier is a person or animal in whom an infectious organism has taken up in. Hepatitis A is transmitted orally through oral and fecal contamination. Hepatitis B is far more contagious than HIV, and vaccination with hepatitis B vaccine is highly recommended for EMTs. I've had that shot multiple times. It is a requirement for your job. You can turn down any vaccination. That's your right. But knowing that you're going to be working in this field, you may want to be up to date on your vaccinations that are required by your agency. So that being the case, now let me dabble in this too. If some of you may or may not know, due to most 99% of the EMS agencies across the universe or across America receive Medicaid, Medicare reimbursements. So if I transport you to the hospital and you're on Medicaid, Medicare, that's a guaranteed payment by Medicaid, Medicare. Well, that's federal funds. So everybody wants those funds because that's really that's how you make a check, is by a Medicaid, Medicare transport, because those are guaranteed payments. Your Blue Cross Blue Shield, all these other ones across the country, they'll pay you, but it may take a 30 to 90 day payment, or it could be longer. So when the federal government pushed out about the vaccination statuses and they want to do this and that, and a lot of your ambulance services required you to have them if you were an employee. It wasn't them making a stand and saying, this is what we're going to require for the betterment of our patients. Ultimately, it was them saying, hey, we got to have our federal reimbursements, and the federal government saying you have to have 100% of your employees vaccinated and or on the medical waiver list and been approved. I don't know that process to receive federal funds. Well, I can tell you, if I was my business, I got to have money. I'm not mad that the agencies did this. I just don't like it. But I had to get my shot because I got to put food on the table. Matter of fact, they're over there eating right now. So I had to do it. So that may be something that we just may have to do in our careers and our lives. We may not fully believe in something, but it may be down to where that's what if you don't want to do it and you decide to terminate your employment with that company, that's okay. That's your decision. I tell people all the time, I don't care what decision you make. I want you to make an informed, educated, and well thought out decision. Do what you want to do. You've grown. But understand that there are some repercussions, and sometimes you're not doing them or doing them. So here's a pretty good chart of what's going on, of charts of characteristics of hepatitis. You can look at that on your book on 15-2 and go over that part. Meningitis. So meningitis is inflammation of the meningeal coverings of the brain and spinal cord. Most forms of meningitis are not contagious. One form of meningococcal meningitis is highly contagious. I probably didn't pronounce that right, y'all. I'm sorry. So our standard precautions, again, gloves, mask, will help you prevent the patients from secretions getting in your face, your mouth, your nose. Just make sure you got the proper ones on and it's worn properly. Vaccines are rarely used for this type of meningitis, and meningitis can be treated in the ED with antibiotics. After treating a patient with meningitis, you must, and I'm going to say this, you must notify your employer health representative, just because that is important. It is contagious, highly contagious, but you can take those precautions and it protects you very well. TB, I've been down that TB road. I've taken care of a TB patient. I took that pill. It's not that big, but it's a big old pill. Took it every day for a year. No alcohol while you're on that pill. It does have adverse reactions, and let me tell you, yes, it does. I can no longer take chest X-rays. Skin. I can't do the skin test. I have to do chest X-rays because I've had a past positive. I'm waiting one day where they're going to rule that out and be like, no, you can go back to skin test. I don't really know if I'll test positive. I don't know. I tested positive 15 years, maybe 20 plus years ago. Never had any issues with it since. I guess medicine worked and don't have no worries about it. Again, patients with coughs are going to be your most highly contagious ones. N95 or a HEPA mask or the most ideal mask that we need to wear. Again, a surgical mask, not this type of setting. Absolute protection from the infectious with the TB does not exist. According to the Center for Disease Control and Prevention, 1/3 of the world's population is infected with TB. The mechanism of transmission is not very effective. Is not efficient. Sorry. So the mechanism of transmission is not very efficient. Having TB skin tests regularly if the infection is found before you become ill. Preventive therapy is always 100%. The whooping cough, also called as bursitis. Whooping cough is an airborne disease caused by bacteria that mostly affects children younger than 6 years old. Symptoms include a whoop that sounds that occurs when they inhale after a cough or an attack. It is very predominant if you've never heard this. And the best way to prevent exposure is to become vaccinated to the DPT or to the Tdap shot. You can also place a mask on the patient and yourself. I've had both of those. I had to take a lot of these shots when I went to the Middle East and was over there for so long. But a lot of those, I've had shots I didn't even really know the name of them for. But I know the Tdap is a must to work for majority of your EMS companies. So MRSA. So MRSA is a bacteria that causes infection and is resistant to many antibiotics. Not saying that it's not receptive to some, but in most of them it is. In healthcare settings, MRSA is transmitted from patient to patient by healthcare providers by unwashed hands. And that's sad. That is sad that and I want to say healthcare in a whole, just don't wash your damn hands. That's gross. Like, that is nasty that we just don't wash our damn hands. It's easy. Just Germex works, but bruh, it's hot water and soap and water, whoop, fixes a lot of things. Some factors that increase the risk of MRSA is long-term antibiotic therapy, prolonged hospital stays. The longer you stay in a hospital, the longer you have potential of being exposed to that. A stay in an intensive care or burn unit. I don't know why that one is. Or an exposure to an infected patient. MRSA results in soft tissue infections. Signs and symptoms: localized skin abscesses and sepsis in older patients. It's gross. I don't mean that in any disrespect to anybody that may have had it. It is something that is not comfortable for the patient either. A lot of times, ones I've seen are very sick. I've transported some MRSA patients that were they were in negative pressure or positive pressure rooms to try to help them, but it's just something that they just like, they don't feel good. It is they sick people. There's not a lot that you can do to help some of the ones that are truly sick. Let's see here. I don't know why it's not cooking. So I think we all are experts on COVID. I don't know if y'all want me to go over this, but I feel like we have had this beat in our heads so much for 2 years that I'm tired of COVID. I hope y'all are too. So MRSA COVID, the coronavirus, it's very dangerous. Majority of it started in Saudi Arabia. It's very prominent in like Afghanistan, Pakistan, Syria. A lot of those issues, it runs rampant over there. Syria is probably one of the worst areas that I'm aware of, and there is no cure for it. We found it in Europe and back in Saudi Arabia. It has been found in the U.S. I don't 100% know this, but I know a couple of people that have worked at the Afghanistan camps that we've brought a lot of people over here and they're still at, and that they tested a lot of them. The ones that I know have told me, yes, we know that we've tested them. We tested them a lot. And that's just the certain facility that I know that they worked at. But this MERS COVID it's rough. It's fatal. We talked about Ebola. It's 2014, broke out in West Africa. We know how bad that was. It was a 6 to 12 day period after being exposed. It can be very severe, or it can be kind of like just a flu. Most of it lasts 21 days. It is a high fatality rate. As you can see, 70%. Again, I was blessed. I was able to go to a COVID facility, learn some awesome stuff, got taught by probably the country's best hospital providers on the Ebola. Travel medicine, the best thing I can tell you guys is be smart of where you're going. Be smart. Do your homework for particular areas that if you travel outside of the United States, let's say Haiti's kind of the big thing right now. They're doing a lot of missions down there, mission trips, and trying to help Haiti. You have to be careful of what is down there. The mosquitoes, you can't drink the water. You get a lot of things. So do a travel study and try to medicate yourself prior to travel. Some of the questions you see here is some of the things that we still ask a lot here lately. But it does getting down to here, what's your source of drinking water? You don't really see this in the US as being a problem unless it's something that is rural. I hate saying that word, rural. Maybe they have their own drinking well that has become contaminated. If you work in a deep rural environment, that may be something. What types of food did you eat? Do they eat natural foods? Do they eat foods that are grown in the pasture that has access to other livestock? So these are some of the questions that we just want to know on travel medicine. Is, if they had any recent travel in or out of the country. Dude, I get asked that every time I go to the heliport. Have you traveled recently? You realize I don't live in this state. Well, where did you travel? Why, I gotta tell you, I just said, I mean, and they ask all that stuff. All right, so obviously here's our conclusion for the night. The assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. We know that some people may not just be forthcoming with information. The condition of medical patients may not be as apparent as in a trauma patient. So do your homework, dig, ask these questions that can help you. Delays in attempt of diagnosing condition can be harmful for the patient. Always remain calm, use your patient assessment skills, treat the patient's symptoms, report to medical control, transport. DeMarcus, you're making marks on my screen. I'm just picking with you. Always make the best decision for the patient and be prepared to handle any combination of conditions. We talk about medical patients who've been involved in a trauma patients that may be a same death in the vehicle that now that's your patient. It's a medical condition. It was caused, your contact was caused by a traumatic event. It's now you're talking to them as a treated medical condition because they have blurred vision and a headache. Could be a concussion. So never stop assessing your patient. I have a thing. Obviously, I like to talk. So I always talk to my patient. Hey, Mr. Fred, tell me what's the last thing that you remember yesterday? And they're like, what's yesterday got to do? I don't care either. I just want them talking to me. That way that I know that they're awake, they're alert, and they're breathing. Your ABCs are taken care of because I'm looking at the monitor to my side. I've already got my vital signs. If for some odd reason I need to go check my vitals again, I'm good. I just like my patients to talk to me. Does anybody have any questions about our medical overview? I know it's short and sweet, and I didn't take a break because I knew that it was short and sweet. Does anybody have any questions about that? I will tell y'all, I am contemplating. I haven't made my decision up yet. I'm going out of town this weekend. My wife and I are going on a us getaway, just so we can get away. And I will not be around computers. So if something happens, you can message on Discord. Please let Rob into the group chat. He'll be aware. He knows that I'll be going out of town. So if y'all reach out to him, he'll be aware. If you happen to email, please email us both so I'm still aware when I come back. Go ahead.
Anything after the module quiz you can't go back to, correct?
That is correct. So we stay in the module. So we were in module 3. We're not going back to module 2 unless there was a pre-issue, as in like your JB Learning was not working. I was aware of. Your sign-in code was locked in. We have some issues right now with the codes. I'm aware of those things. Rob and I both are. So let's say, Mario, I'm going to use your example. If you didn't take chapter 11 test, we're not going back to that. That grade has been assigned and that chapter's locked.
It's so funny that you use that example, but it's okay.
Rodney, I think so. Pascagoula, right? Rodney, you're with the Pascagoula group, is that right? I just want to make sure I'm on the same page. Oh, they don't want you in their group. Oh, it's okay. Yeah, Rodney, just shoot me a message on Discord. I'm pretty sure I'm on the same page, but now Pascagoula is saying, come on down. No, and Pascagoula, I'm still aware of you guys, so that's the reason why I was wondering. But no, if Rodney, like I said, just shoot me a message on Discord. I'm pretty sure I'm on the same page as you are, but I slept and woke up and did something different. So that's probably why it's not recognizing. Okay, all right. So you're squared away. I don't know what you're perfect. I think you and I are on the same page, and I had to go back and look at my notes. But yeah, guys, that's it for tonight. Y'all want this? Let me see if I can push it. There's your class code for tonight. 9 at 7 JP. what I was going to tell y'all before anybody logs off, I have not made up my mind yet or not. If I'm going to teach Thursday, I may do a pre-recorded, me sitting just talking to the screen, going over things, and y'all will watch that Thursday night. I just don't know. Depends on what my wife and I decide about leaving for vacation. So I would do my best to let y'all know through Discord on what's going on. If I just decide to teach class Thursday night, nothing will happen. We'll continue on the process. Other than that, y'all have a wonderful night and good luck on your test whenever it opens. See y'all on the next adventure.